Okay, only 3 acute complications of diabetes. They are hypoglycemia, DKA, and HHS. DKA, HHS are similar. So the shortest topic, let's start with hypoglycemia. So questions on exam is, of course, we need to know what causes it. So what will cause, we are on page 1512. So what are the causes of hypoglycemia? Okay, they're mentioned here. When you took too much insulin or too much hypoglycemic agents and you didn't eat enough food, or you have excessive physical activity, meaning what is the effect therefore of physical activity on glucose levels? Now, when you're exercising, what are you doing to your blood sugar? You're burning it. So therefore it will do what to your glucose levels? Decreases it. So can you say exercise is like insulin? Exactly. Okay. Right. It can also be, other reasons would be you took the wrong type of insulin. Or maybe it's not you. Maybe it's your nurse that gave you the wrong type of insulin. Or maybe you were given the wrong dose of insulin by your nurse. Okay. Or you're simply not eating. Right. Manifestations, well, it depends. How bad is your hypoglycemia? So we have mild, moderate, and severe hypoglycemia. So these are the manifestations. We have 3 paragraphs. In mild, those are your manifestations. Basically, they are symptoms of sympathetic stimulation. Yeah. Okay, so therefore, what can you say about hypoglycemia? If it stimulates the fight or flight response, is it life-threatening? Yes, hypoglycemia is life-threatening. It triggers, your proof is it stimulates epinephrine release. Have you ever seen any other, let's say you are, what else would be a problem for you? A headache. Have you seen a headache stimulate sympathetic nervous system? No, right? So therefore, if something stimulates your catecholamines, what can you say about that condition? It's serious. Yeah, life-threatening. In moderate, these are your manifestations. You have the feelings now, you're hangry. Yeah, have you ever been hangry? Hangry. Yeah, I'm hangry right now. Angry. Severe, these are your manifestations. Now, it's important to note that use common sense when you're treating hypoglycemia, because every person tolerates hypoglycemia differently. So in my, I've been a nurse 29 years now. It'll be 29 years in July. I've seen different reactions to hypoglycemia. I've seen a patient with a glucose. What's the normal blood glucose? Well, technically the book says 70, yeah, to 110. But it's 65, okay, have at it. I've seen a patient with a glucose of 60 who was unresponsive. She was limp, unresponsive. Slapped her around, no response. Okay, 60. Whereas I had a patient who had a glucose level of 25. Now, 25 will not register on a glucometer. 25 will be from the lab, okay, on chemistry. So I wasn't even checking his sugar level. We were talking, right? This was an old geezer. He was 90 something years old. We were talking, carrying on a coherent conversation. Okay? We were joking around. Lab called me. So I picked up my phone, because some hospitals give you phones, they'll call you directly. But I said, oh, lab, yeah, what you got for me? Your patient, and then she gave me the name. Okay, and she said, this glucose level is 25. And I said, let me clarify that. 25? You sure 25 milligrams per deciliter on this patient? Are you sure? And I said, I'm talking to him. Yeah, you want to talk to the patient? Okay, because it's not expected. I mean, 25, they're usually unconscious. Okay, but this guy was wide awake, fully coherent. So what am I getting at here? Since the manifestations vary because people tolerate hypoglycemia differently, how should you approach the intervention? Here's our intervention now. How should you approach it? Should you necessarily follow what the textbook says? Meaning, I'm just saying in practice, okay? So let's say here, in mild, their recommendation is you give 15, the 15 to 15 rule, meaning you give 15 grams of simple carbs and then recheck the blood glucose in 15 minutes until you get to 70, okay, until you get to normal. Meaning you repeat it until you get to the normal, okay? So meaning the patient's no longer hypoglycemic. All of these interventions here are temporary interventions, meaning they will raise your blood sugar momentarily. How do you guys maintain your blood glucose levels? How come none of you here are hypoglycemic or unconscious every single day? How come? What do you do every day? Fernando? You eat, yeah? Okay, same thing here. So since these are only emergency interventions, like giving the 15 grams of carb, examples are crackers, 3 grams crackers, 8 ounces of milk, right? 1 cup of orange juice. Those are the usual interventions that contain 15 grams. After that, and then if it achieves your goal, which is you're at least 70 or higher, what do you do next? Are you done? Meaning, can you go clock out? Because what will happen to that sugar in the next hour? It will drop again. So therefore, after intervening, what do you do next? You gave the 15 grams. What's next? Feed them. Okay. Give them a meal or a snack. Okay. That way, it won't happen again. Are we clear? All right. So this is for mild. Okay. So I won't read the entire thing for you. Again, you're capable of 12th grade level reading. Okay. Now I'll go to the parenteral option. Now the parenteral options, there are 2. We have glucagon, given IM or sub-Q, and then we have dextrose, 50%. You give the whole 50%. 50% is in 50 ml. No, a vial, 50 ml vial. Or some orders will say 12.5 grams versus 25 or versus 50. So follow the order. But as you can see here, we only give the dextrose if the patient has a working IV access. Because sometimes, it happens that your patient doesn't have one. So your only option, therefore, is glucagon, okay, which you can give IM or sub-Q. Let's say the scenario that I gave earlier. My patient's sugar level is 60. That is mild, correct? It's mild hypoglycemia. What did it say again here in mild? What am I expected to give? Food, yeah. I'll give them crackers or milk or juice. Can I give it to the patient who was unconscious? No. So therefore, it's mild, but I can't give the oral option. So what do? I go with the glucagon or dextrose option. Are we clear? On the other hand, that old geezer that I have, who sugar was 25, is that mild, moderate, or severe? That was severe. Do I give him necessarily glucagon or dextrose? Do I have to? No. Why? He's conscious. Can he eat? Yes, he's capable of eating. So do you want a needle or do you want to eat?
You want to eat.
I don't know about you. I'm going to eat. Okay, so here's food. I'll enjoy food better than an IV injection or an IM injection. Are we clear? All right. And of course, you educate the patient. What were the causes again? How did this happen in the first place? Okay, so we had the causes up here. So these are the causes. So what do you teach them? The causes. Okay, so that this doesn't happen again. Because can this happen again? Is it dangerous?
Yes.
Yes. What if the patient is alone? You have grandparents still living? Okay, what if they're diabetic, they have hypoglycemia? When do you see them during the day? No, right? Is anyone with them?
No.
Who's checking up on them while you're in school? So if they say, what time do you leave the house or their house, for instance, let's say you live with them or they live with you. So what time do you leave for school? On Thursday, 8. So let's say they had hypoglycemia around 8:30. What time are you gonna get home? Okay, so 8:30 and 5 o'clock. What will they look like when you get home? You see you see my point, yeah? Okay, so therefore, is it important that the patient is educated? All right, so that they know how to prevent it and signs and symptoms, yeah? Because the signs and symptoms, remember, there's confusion. Are you aware if you're confused? No, this confusion is not the same as, let's say you're taking a quiz and then, oh, I'm confused with this. Is that really confusion? That's not confusion. Confusion is you're not aware. You have low oxygen or low blood sugar. That's confusion, yeah? Okay. Any questions on hypoglycemia? Very good, children. Let's go to DKA. Right. So what is DKA? This is one of two hyperglycemic complications of diabetes. What are the causes of DKA? First of all, who develops DKA? This will happen to type 1 or type 2 diabetes. Used to be only type 1 during 20 something years ago, only type 1 diabetics develop DKA. Now, lately, we're seeing more and more type 2s developing DKA, okay, which is weird. So causes are, manifestations are they have hyperglycemia. We'll look at the numbers shortly. There's dehydration. Now, the dehydration here is, remember osmotic diuresis we discussed in week 1? This is osmotic diuresis because the sugar is so high. So what will osmosis do? It will, because the sugar is, let's say, 350, 600, 800. So what happens to the concentration of your blood? Very high. According to osmosis, what will happen? Water will move from where? Which is from where to where? From the cells into the bloodstream. Okay. So what will your kidneys do if they see all of these blood volume now increase? What will they do? Increase what? Urination. So will the patient become dehydrated? Yes, from osmotic diuresis. And then finally, we have acidosis. Now, the acidosis here, we'll look at the pathophysiology. How does the pH drop? Okay, so let's look at the trigger first. So how did this happen? I'm diabetic. I have type 2 diabetes. So how do I develop DKA? Usual cause is I got sick. Now, the sickness doesn't have to be physical. I could be mentally or emotionally ill. Okay, I'm not feeling good. So in all those circumstances, if I have the flu, I have COVID, I have some infection, or I'm sad. So let's say Miss Yaya rejected me. Okay, I've been sending her love notes and she's rejecting me. Plus, she didn't just say no. She said stuff. Okay, she said, nah. She insulted me. So how will that make me feel? Yeah, that will insult me and then, just drag me down again. She could have just said no. But then she said things, so now I'm not feeling well. So what will happen to my stress levels? And what hormone will my body release? What hormone will I release? Not feeling well. Okay? Emotionally, physically. What is the stress hormone? Cortisol. What will cortisol do to my sugar levels? Okay, all right. So therefore, plus when I'm not feeling well, am I eating? Am I drinking? So if I wasn't educated the way I am now, let's say I don't know anything about DKA. I've never had DKA. All I know is Yaya is not going out with me. I don't feel well. I'm not eating, I'm not drinking. So if I'm diabetic, what will I, in my simple understanding of diabetes, think about my glucose level? Is it going to be high or low? I'm not eating or drinking. I don't have any appetite. All I'm thinking about is, yeah. So what will I believe my sugar levels are? Of course, I'm going to say low, right? So will I bother checking? No, I will stop. You know how much glucose test strips are? If you have no insurance, it's expensive. Okay? So I won't bother. I know it's low. Okay? I know because the last time I ate was yesterday. Okay? When she, called me names yesterday, I stopped eating. So I haven't checked my sugar. What for? What for? I know it's low. But little do I know is this is what's happening in my body because I'm not checking my sugar. So am I taking my medications? No, because I believe that my sugar was low. So does it make sense that I could taking my insulin and my metformin? No. What am I? I'm not suicidal. Okay, I'm just sad, but I'm not wasting my medication. Plus, I believe my sugar is low, so I don't need to take my insulin or my metformin. Yeah, let's say I'm type 2. So this is what's happening meanwhile in my body. Because I don't have the drugs and I don't have insulin, what's happening to my cells' ability to get the sugar? Can my cells get sugar without insulin?
Yeah.
Can insulin enter, can glucose enter the cells without insulin? No. So what's happening actually to my glucose levels? It's actually going up. Okay, so I don't know that because nobody told me about it. Okay, so this happens to uneducated, meaning not illiterate, but nobody explained this to them. Okay, the effects of illness on blood glucose levels. So meanwhile, no, and this will happen fast. Within hours, I can go into DKA. Remember, I started feeling this way yesterday. Okay, I stopped eating, stopped checking my sugar, and stopped taking my medication. So that's only less than, let's say even less than 24 hours. I could go into DKA. This is what's happening. So my sugar continues to go up and up. And what are the 3 P's of hyperglycemia? Okay, so I have that. And then meanwhile, I'm having osmotic diuresis now. So I'm peeing a lot, not aware of it. Okay, I know I'm peeing a lot, but what was I thinking again? All I was thinking about was, yeah. Okay, yeah. Okay, or my illness. Let's say I have the flu. Okay, that's all I'm thinking about. I'm tired. I'm in bed. So I'm losing so much water. Okay, I have the 3 P's. And then what is the sequence again of the how our body responds? Because the cells, remember, are they getting sugar? No. Is it because there's no sugar? Is it because I have no sugar? No, I have plenty of sugar. What do I not have? Insulin. I wasn't taking my insulin, okay, because I wasn't feeling well. I'm not eating, I'm not taking insulin. The body doesn't know that. All the body knows is, are my cells getting sugar? Are my cells getting sugar? Why? There's so much sugar. Why are they not getting it? Because there is no insulin. So without insulin, my body cells can't get the sugar. But do I have enough sugar? Yes, in fact, I have too much. Okay, so this goes on hour by hour, hour by hour. So what will my body react? The cells are saying, we need sugar. So what will my body do? Okay, first step is I'm gonna break down glycogen, yeah? So glucagon will be released, emergency hormone. Our body produces glucagon. You know that, right? Okay, so glucagon released, it will turn glycogen, which is in my liver, into glucose. Okay, so that will raise my blood sugar, correct? Will that solve the problem? Can the cells get the sugar now? Still no. Remember, what was the problem? No insulin. Sugar is plentiful. We have enough sugar, too much, in fact. The problem is I wasn't taking my meds. So after that, glycogen has been exhausted. I have no more glycogen. The cells are still saying, we need sugar, please. We're hungry. We need sugar. So what would my body go after next? Fat. So now fat will be broken down, turned into glucose. But what will also be formed when I break down fat? Ketones. Okay, here. So effect of insulin deficiency, lipolysis. So sugar will be taken from the conversion of fat into glucose. A byproduct is ketones. Ketone bodies are acids. So as they accumulate in my body, that will turn my pH into acidic. Okay, so my pH level will drop, go from 735 to now 7.34, 31, 7.3, etc. Furthermore, I will also start breaking down protein. So after fat, proteins will be broken down as well, increasing my glucose levels. Now, a diagnosis of DKA is made when my sugar is 250. You are technically in DKA. 250, 800, but I know the book says 800, but there's really no limit to the glucose level. This higher number has no limit. If you're still alive, this can reach 1200, 1500, 1800. There's no limit, okay? But because the symptoms, the whole condition develops how long? Did it take days or just a matter of hours? Just a matter of hours. It's easy to get to 250. Okay, so this developed within a matter of hours. I was already in DKA. So let's go to my manifestations now. Don't worry, I'll go back to the prevention. So what do I teach the patient? Okay, so what should I have been taught? The 3 Ps, and then what will I also have once I have the acidosis now? I will have, what do we call that abnormal respiration? Okay, Kussmaul's. Okay, so I have this acetone breath, and I will have deep rapid respiration. It's called Kussmaul's respiration, right? Let me emphasize this. I forgot to mention it. So since the sugar levels in DKA can vary, it starts at 250, but again, there's no limit to the upper number. It can go higher than 800. The severity of DKA is not necessarily related to the glucose level. What does this mean? The severity is related to the pH level. How acidic is my blood pH? Okay, do you understand? Okay, so the severity is related to not to the glucose level. Okay, just because my sugar is 250 doesn't mean it's mild. Okay, it really depends on my pH. Okay, so let's go to, before we intervene, let's look at the prevention first. So I explained the pathophysiology. This is what happened. What was the root cause again? I stopped taking my insulin. What triggered this? Why did I not stop why did I stop taking the insulin? I was sick. Gaia made me sick. So it's a physical illness, emotional, or psychological illness. So therefore, can this also happen if a patient had no idea that they were diabetic? Yes, another instance of DKA is the patient had no idea. This is the first time they found out that they were diabetic. Does that make sense? Okay, but most cases, of course, the patient already knew and they were sick, okay, and they were not educated. Or sometimes they can't help it. Hey, they just got sick. I mean, can you totally prevent COVID? Yeah, we didn't, right? 4 years ago, everybody was getting COVID. So our diabetics were going into DKA, okay, in addition to COVID. So how do we prevent it? So let's educate the patient. This is our prevention. sick day rules, chart 46-9. So the next time, let's say the patient survived DKA, yeah? So, or let's say they were diagnosed, oh, I had no idea I was diabetic. Okay, well, now you know. So from now on, this is what you do. When you're sick, okay, let's say, so I know they will educate me. Okay, so next time you see Yaya, this is what you do. Okay, we can't do anything about Yaya. She doesn't like you, forget it. There's other fish in the sea. Okay, but no, I like this fish. Okay, he said no, no more. Okay, give it up. You'll have DKA again. So how do I prevent it? Continue to take your insulin and anti-diabetic agents as usual. Of course, if the sugar is too low, then don't take it. All right. Continue to test your sugar. In fact, when you're not feeling well, check it more often. Okay? If you're used to checking it twice a day or once a day or 3 times a day, we'll check it more often. Okay, because your sugar is going to be out of control. It's going to be higher than usual when you're not feeling well. And of course, report. Now, urine ketones. Now, how do they know they have ketones in their urine? Well, simple. There are ketone kits in the pharmacy. So your local pharmacies sell them, covered by insurance. Or if you have no insurance, they're not expensive. Okay, they're like $10. Okay, the kit is cheap. So get the kit, test your urine for ketones. If they're positive, tell your doctor. Keep eating. Okay, do not stop eating. Eat, take your medicines. If you can't take anything down, let's say you're vomiting, okay, or the patient's unconscious, then of course unconscious, take them to the hospital. But patient can't keep anything solid down, then give them, what's the supplement, the nutritional supplement for diabetics? What do you call that? There's a special nutritional supplement, nutritional drink, Glucerna. Okay,
Oh, yeah,
so we give them
Glucerna.
Glucerna. Okay, drink Glucerna. If you can't eat, drink Glucerna. Okay, that's a meal for you. Here, or stay hydrated. Remember, there's polyuria, yeah? There's 3 P's, so stay hydrated. If the symptoms can't be controlled at home, then it's time to call 911, right? Take the patient to the hospital. All right, let's go now to once we're in the hospital, what is the management? Our goals are the following. We're going to correct the dehydration, correct the electrolyte loss, and correct the acidosis. Now, this is going to be your first patient. Your first simulation patient will be a DKA patient who happens to have low blood count as well. All right, so you're expecting to give IV fluids as well as blood transfusion. Okay, so we'll start that maybe 2 weeks from now, right? So since these patients are dehydrated, initially we will hang normal saline first. What type of solution is normal saline? Where will this go? It will stay where? In the body? Of course, everything will go into the body. Where, which compartment? In the blood vessels. Okay, so it will stay in your bloodstream. So therefore, what will this do to your blood pressure? It will increase it. Okay, so most DKA patient comes in with low blood pressure because of the severe dehydration. So they come in, we give them start IV fluids, 1 liter, sometimes more. Once the blood pressure is normal as in over 90 systolic, over 60 diastolic, once that's achieved, then we switch to half normal solution. Because remember, the cells are dehydrated, correct? So is this appropriate? Yes. Where will this fluid go? Into the cell. Okay, so but what's the first fluid that we hang? Normal saline first. Okay, so picture it this way. So I arrived at the hospital at 3:39 p.m. They did testing. They concluded I have the symptoms. They checked my labs. We'll look at the labs shortly. They checked the labs. Okay, so I have the pH is low. I have the glucose, which is over 250 and higher. I have Kussmaul's respiration. Okay. So they diagnosed me, you have DKA. Okay, so we'll start fluids. So they gave fluids at, let's say, 340. They started the fluids. Will that fluid finish right away? It'll take an hour, right? Okay, so meanwhile, while that's starting at 341, what's my next step? Because I can't have the half normal yet, can I? I have to finish that bag of saline first. So meanwhile, what will the nurse do? Let's go to the next part. Let's go to restoring electrolytes. So my labs will show the doctors how are my electrolytes. So they'll correct them if needed. Okay. So I get additional orders, whether it's magnesium, potassium, whatever is abnormal. So I'll get that. Also in the same hour, which reminds me, if I'm given potassium, what are the guidelines again? If let's say my potassium is low, what do you check before giving me my potassium? What else? Kidney function or urine output. Okay, make sure I'm able to excrete it. Okay, all right. Reversing acidosis. Remember, this is first hour. Okay, you just started the IV fluids. Now you're going to give me insulin. Okay, because I don't have insulin yet. Okay, but the priority was fluids. Okay, and then electrolytes, if any, and then this is the same hour. So let's say it was started at 340. Yeah, my IV fluids, my normal saline. Now 341. Doctor ordered, okay, here's the insulin. Give this patient insulin. Now there are 2 insulin orders here. 1 bolus and then also a continuous infusion. What type of insulin? Regular. What route? IV. So regular insulin is the only insulin approved for intravenous administration. So first order is, let's say the doctor orders 0.1 units per kilogram as a bolus. I weigh, let's say 80 kilograms. How much insulin will you give me IV? I weigh 80 kilograms. The order is 0.1 units per kilogram. How much will you give me? Ms. Lefleur? Huh? So how much insulin? How many units will you give me? 0.1 units per kilogram. 8 units. Okay. How? We'll discuss that next week. We'll practice your we will prepare for your simulation. Okay, next week. That's what we'll do in lab. So you gave me the bolus insulin. The next order is you're gonna give it to me in an infusion. So let's say the order is, I don't know, 0.1 units per kilogram per hour. And the bag is labeled 1 unit per ml of insulin. So how much will be my infusion rate? 0.1 units per kilogram per hour. How much will I receive? If the bag is labeled 1 unit per ml. The answer is 8 mLs per hour. I'll explain later when we get to the lab next week. So that is now infusing. So how many pumps am I expecting here? Let's say we're using the same pumps as we have in the lab. So how many pumps are we talking about? At least 2, because I have what's running on one pump? My saline. What's running on the second pump? The regular insulin. Okay, and then you gave me the insulin bolus. Okay, so both are running. So how does insulin reverse acidosis? How does it help with the pH? What led to the acidosis in the first place? What did I not have? I didn't have insulin. So therefore, my body was breaking down fat. So how do I stop my body from making ketones? To prevent me from, I should be prevented from breaking down fat. How do I do that? By giving me insulin. So therefore, insulin does not only lower blood glucose, it also reverses acidosis, because now my body will stop breaking down my fat. Okay, remember, I invested a lot in this fat. I should not be breaking this down. Okay, no, I'm just kidding. Okay, so now this is all in the first hour. Let's say 1 hour later, the NS is finished. The bag of saline is now finished. Now what will happen next? It's empty. The bag's empty. The doctor ordered half normal saline. Now, let's go back to so this will be the next leader. Now let's go back here in reversing acidosis. Last week, we discussed treatment for hyperkalemia, which was, what was one of the treatments that will reverse, which will shift potassium from the bloodstream into the cells? What was the route? And what was that type of insulin? Is it different from this one? This is exactly the same regular insulin IV that I gave for the patient with hyperkalemia. Now I'm giving to the patient with DKA. So what will happen to my potassium levels once you start infusing the regular insulin IV? So therefore my potassium levels will do what? It's gonna shift. So what will you expect to happen to my potassium levels as this therapy is ongoing? It's gonna drop, correct? Right, so we learned last week that was it easy or hard to correct potassium once it's low? It was hard. So do I anticipate that? Meaning, are you gonna ask if it drops or when it drops? It's gonna drop because you're giving regular insulin IV. It will drop, of course, that's the reaction, right? So what do I do now? What will I ask the doctor to add to this bag of fluid? Can we add potassium in it? Yes, why not? Okay, so doctor, you'll tell the doctor, hey doctor, we're running regular insulin. It's gonna lower potassium. What do you want to do something about that? They say, okay. The doctor can give you an option. Okay, let's add, let's change this fluid to half normal with some potassium. Okay, so maybe they'll order half normal saline with 40 MEQs or maybe with 20 MEQs. Okay, to anticipate. Okay, since we're lowering it with the regular insulin, we might as well start replacing it. All right, and then you continue the therapy. Let's look at when the patient is considered treated. Now, DKA is considered resolved once the sugar is under 200. Okay, DKA is done. So once DKA is resolved, do we still need the regular IV infusion of insulin? Do we still need no more? So we'll switch to subcutaneous now. We'll still check the sugar, but no more IV insulin. So when they give the insulin subcutaneously now, okay, no more IV. So therefore, do we still need the potassium replacement? No more. Now, if the sugar drops too fast, the doctor may order dextrose solution. It's written somewhere here, right here. So if the sugar is dropping too fast, doctor may order D5 normal or D5 and a half, okay, if it's dropping too fast, okay? Or sometimes here, to avoid a rapid drop in glucose, okay, they may switch to that as well. But that's not our decision. That's the doctor's decision, okay, to use dextrose solutions. And that's it for DKA. Oh, one last thing. When you're priming the bag of insulin, here's a warning. Read this, and what do you understand by this? Thank you for reading, Miss Jurgen.
By handing the insulin drug, the nurse must flush the insulin solution with the third part of and discard the first. Insulin molecules enter to the inner portion of plastic IV. Therefore, the initial fluid may.
So what does this mean? Do you understand the paragraph? This warning, do you understand what I say? So when you're priming, you saw me prime the bloodline earlier, right? With saline. Okay, so you're doing the same on an insulin bag. So you're priming, instead of saline, you're priming a bag containing insulin. What does this say I do with the first 50 ml? I need to get rid of it. Why? Why am I wasting? Let's say it's a 250 ml bag. Why am I wasting the first 50 ml? Very good. It's because the first 50 ml of insulin is not going to go into my patient. Meaning for the first 50 ml, if I run it, what is the patient receiving? Just the IV fluid. Where did the insulin go? It stuck to the IV tubing. Okay, so you need to waste 50 mLs worth. That way, when it starts infusing, is my patient getting insulin? Yes. You understand what I'm saying?
Yes.
Any question?
No.
Okay. All right. For HHS, it's really the only difference between HHS and DKA is HHS only occurs in type 2 diabetics. Only type 2. The teaching is the same, the treatment is the same. However, since DKA happens to type 1 and type 2, and what was the trigger again? No insulin, right? Here, because this only happens in type 2, what's the difference between type 1 and type 2 diabetics? I'm type 2 diabetic. So if I have HHS and not DKA, what triggered my condition? Is it no insulin or not enough insulin? It's not enough insulin, meaning I have enough insulin to prevent ketosis. Everything else is the same, but there is no ketosis. I'm not breaking down fat because I still have insulin. Another difference is, here's actually a comparison. Okay. Another difference is the onset. So we said, how fast did the DKA start? A matter of hours. Now, HHS develops over several days. Okay, so therefore, if it developed over several days, how dehydrated am I? And how high is my sugar? Higher. So I'm more dehydrated, my sugars are higher than DKA. You understand? So which was a higher mortality here, DKA or HHS? HHS people have a higher mortality. And because there's no ketosis, will you see Kussmaul's respirations in HHS? No Kussmaul. So what will I have symptoms of? Only change in mental status, meaning I'll be tired. Okay, I'll be tired. And what will I do when I'm tired, when I'm dizzy? I'll go to sleep. Will I wake up? Probably not. That's what makes HHS very dangerous. Okay, because there's no Kussmaul's respiration here. All the patient will have changes in mental status. Okay, they'll get sleepy, dizzy, they'll go to sleep, and then that's it. Peaceful death though. Look at the sugar. Okay, so slower onset, higher sugar, normal pH, no acidosis. Okay, no ketones. Okay, because there's no ketosis. Right? Both will have AKI. Can this cause AKI? DKA and HHS? Which type? Pre, intra, or post-renal? Pre-renal AKI. And we already discussed AKI last week. Okay, so we're not repeating that. All right, so what's the also in severe cases right here, I missed the part of there's bicarbonate here under reversing acidosis. Right here. There's a part where we give bicarbonate. I can't see where exactly, but it's an option. If the patient has severe acidosis, meaning the pH is less than 7, patient may receive sodium bicarbonate to reverse the acidosis. Will we need that in HHS? Why not? Is there ketosis in HHS? None. Okay, so you'll see that here. So when do we give bicarbonate again? If the pH is less than 7, severe, meaning we can't wait for the insulin to stop the fat breakdown. Okay, the patient will die now if we don't give bicarbonate. Do you understand that? Bicarbonate is a base, it's alkaline. So what will happen if you give alkaline solution to an acidic patient? Okay, neutralize. You understand the purpose? Okay, so we give bicarbonate IV if it's really severe acidosis, because at that point it will fry the brain. The patient will have permanent brain damage. if we don't treat the acidosis. Okay, that's it. I'll stop talking.